Thank you, everybody. It's a great pleasure to be here and talk to you today about some of the research that we're doing, some of the pioneering opportunities that we've had at the Mayo Clinic. As you can see, unlike my predecessors, I'm a Ph.D. scientist. And so what's important, in addition to the commitment that the physicians have at Mayo with respect to developing new and novel innovative strategies for the treatment of a wide variety of diseases, Mayo also employs, as part of its commitment to research, a number of Ph.D. scientists, hundreds of Ph.D. scientists, who sit around and think of novel, silly ideas in some cases and try to determine if those are going to work and be the next advances in medicine. And so I think that's a very important point. And another important point is, too, the interval between haircuts, too, can be a little bit longer if we're allowed to sit in the laboratory for 14 hours a day to try to study. Immunotherapy, there's a revolution in immunotherapy of cancer, and we've used immunotherapy for many, many years. Somebody talked about interferon for the treatment of cancer early on. We have, of course, the development of monoclonal antibodies that was already discussed, rituximab, and I'll talk a little bit about Herceptin. Those have been going on for many, many years. The revolution has to do with the fact that we can identify the molecular switches, or we have identified the molecular switches, which has enabled us to turn on, or kind of, in the sense of a rheostat, so you have that light switch that you can, turn up and slowly turn back to get different intensities of light. We can do that now with the immune system, so that we can turn it up enough to attack the tumor, but not any tissues that are in the body. So we have, several conflicts of interest in some of the things that I'm going to talk about, and I have to show this slide. But this is important, because if we didn't have any conflicts, at least from what I've heard, we're not doing anything. And in fact, we are engaged in developing a number of new therapies at the bench and partnering very early on with a number of biotechnology companies to make sure that we do have a success story, that this is able to see the light of day in the patient population that it was intended to. So the Mayo Clinic has been instrumental since the early 1970s in the development of immune-based approaches for a wide variety of diseases. And, typically I take about 36 hours to teach immunology to my medical students. And I've tried to capture that all on one slide here, so that you can get a sense of the immune system. It's actually quite vast and complex. It consists of multiple arms, and we're only looking at one arm here. It consists of what's called an innate arm, which is the rapid-acting arm. This is something that's going to stop bacteria or viruses or fungus from entering into the body and causing infection. And then ultimately, if an infection is set up that isn't eradicated by this so-called innate immune response, then you have the adaptive immune response. The adaptive immune response is very exquisite in terms of its specificity. So one thing you may not know is, you've heard of this idea that there are T cells in the body. So there are what we call CD8 T cells and CD4 T cells. And each one of these T cells in your body is different than the other genetically. And that difference allows them to make unique drugs that they position at their cell surface, called the T cell receptor. And so think about 1 teaspoon of blood here. You have 10 million unique T and B cells. So B cells produce antibodies, which are free-floating molecules that can go around and target microbes or cancers, etc., anything that causes diseases. So you have 12 million per teaspoon, and each one of those is unique, and they recognize something very specific. And in fact, it's the best drug-making machine that I know of. If you want to put a number of zeros, the specificities that your immune system encompasses is 1 × 10⁸ different molecules that can be uniquely recognized. And so we talk about the 40 or so vaccines that we have for a variety of different human conditions. Keep in mind that that is only touching not even the tip of the iceberg, not even close to the tip of the iceberg. We can continue to train the immune system. We're doing that not only for infectious diseases, but we're doing that for cancer. We're doing that in a number of different ways. And I'm just going to give you, because I have very limited time, just small vignettes of the types of approaches that we're using at Mayo Clinic and other clinics across the globe to catch this revolution, which seems to be so effective in treating many different kinds of cancers. I'm going to put a little biology in there. I don't have any nice, structural things or anything like that, because we deal with small molecules and where I have, in some cases I have some good visuals. But I want you to keep in mind that there are multiple different kinds of T cells, and two in particular are CD4 helper T cells, and another group is called the CD8 cytotoxic T cell. And then you have B cells, which I already mentioned, produce antibodies. Each T cell and each antibody is extremely unique. And I'll get into a little bit more about what that means in a number of different slides. So what's uniquely different between T cells, these two things here, and B cells is T cells recognize small fragments of microbial proteins that are sitting at the cell surface. And it was back in the 1970s, actually, and one of the professor emeritus in the Department of Immunology discovered what we call MHC class II, which we know to be very important in activating a subset of these T cells, the CD4 helper T cell, which is very important in coordinating an effective immune response against microbes and cancer. And because of these discoveries of these molecules called MHC class I and class II, or HLA molecules, or transplantation antigens as they may be called in some areas, we've been able to describe what's unique about tumors that allows us to target specific regions of unique proteins which are on the cell surface of tumors. But perhaps the most important thing that has driven the revolution in immunotherapy in recent decades has been the understanding of how the immune system gets activated. Because if you think about it, you have all these cells in your body, and you may have cells that recognize your pancreas, you may have cells, and in fact you do, but they don't get activated because there's a series of decision-making processes that come into play, that go into effect to activate immunity specifically against a microorganism or a cancer. And that's shown here in what I like to refer to as a kind of a list of different molecules that either turn on or activate T cells, or turn off or inhibit the activity of T cells. And it's actually a combination of turning off and turning on that allows for the different types of cellular responses or antibody responses against microbes. And perhaps one of the most fascinating areas, and something that Dr. Ferrugia alluded to in his first talk about immunotherapy in a patient with malignant melanoma, is this molecule called PD-1 and its cognate ligand or receptor called B7H1 or PD-L1. These are the mainstays of what we call immune checkpoint blockade therapy that's been so effective in a wide variety of cancers. And in fact, Mayo has been instrumental in developing the biology behind this. And in fact, in 1998, B7H1 or PD-L1, which is now targeted in a number of different tumors, and is being investigated in a number of clinical trials, was discovered at the Mayo Clinic a couple of years following the discovery of its cognate antigen PD-L1, which is also targeted with a number of different monoclonal antibodies that are available now for the treatment of a variety of different cancers. So we've known now for many, many years that the immune system can naturally recognize cancer. We all think of the immune system as being something that can recognize bacteria, viruses, fungus, and that's how we get protected. But in fact, in addition to that, the immune system recognizes cancers. And we've known back from the mid-1990s that some patients, not all patients, develop immune responses against their cancer. We can detect that in the blood. We can detect those T cells. We can detect those antibodies that target specifically the tumors. We see here, this is just an example of a study that I just pulled from the internet, one of the publications, and this is in triple-negative breast cancer. And you can see here, and this is what we call a Kaplan-Meier curve. And so this looks at the probability of being disease-free, but in simpler terms, the number of patients that are disease-free at any given time following diagnosis of their therapy. And those that demonstrate a T cell response that migrates into the tumor have less of a chance of relapse. How can we capitalize on these findings and stimulate the body's immune system to destroy cancers that are either there, bulky malignancies, or prevent cancers from developing in the first place? And that's what I'm going to talk about, is both of those elements. So let's all kind of wrap this up into one slide to try to understand what we're trying to do with immune therapy. So in a patient with cancer, it looks as though that the immune system is blocked at multiple places. So normally what we want to do is create an acute inflammatory environment, just like what happens when your body is trying to tackle the flu virus, when it's trying to tackle something that has moved in through the skin, or a bacteria or a virus or something like that. It creates a local inflammatory condition in which it acutely eradicates that infection. And it does so very similar to what happens in a tumor. And the reason I'm showing that is because I want to emphasize that tumors that do grow out in individuals have learned to behave much like a bacteria or a microbe, in that they can block certain aspects of the immune system, thereby preventing the immune response from eradicating or destroying the tumor. And so typically what happens is you have the tumor here, and it releases a number of different tumor antigens. So these are proteins or carbohydrates into what we call the microenvironment, so locally. And what we want to happen is we want these so-called dendritic cells, which are also part of the skin and tissue, to pick up the antigens that are released by the tumor and move quickly back to something that we've all heard about, lymph nodes, where the immune response is activated, and activate those T cells. And so we have all of these resting T cells, and they shuttle through the lymph node. And if they find their particular target, then they'll clonally expand in the lymph node, and they will migrate to the tumor microenvironment, to the infectious microenvironment, where they will undergo further clonal expansion. That's what we want to happen. This is what we want to happen. But it's stalled at many different places. In fact, we know tens of mechanisms by which tumors use to block various aspects of what we call the tumor immunity cycle. And so there's a number of different strategies in which we're trying to break those blocking points or override them, so that we can move from what we like to call a chronic inflammatory environment, which does nothing, to an acute inflammatory environment, which gets rid of the tumor. And so there are a number of different ways that we're doing that. And I'm not going to talk about all those ways. The 4 common ways that you're going to see and that we engage at Mayo Clinic is cancer vaccines, monoclonal antibody therapy. You've heard a little bit about adoptive T cell therapy. That was the CAR T cells that were used for leukemia and lymphoma. And then also immune checkpoint blockers or inhibitors. And I'll come back to that in the end, but this is where the revolution began with respect to industry really focusing on how we can harness the power of the immune system. Now, remember, the reason that we vaccinate is because we want to try to mimic that primary immune response. So take the flu, for example. Flu gets in 7 days later, it causes an infection, and it's a horrible infection that goes on for many, many days, sometimes weeks, and leads to illness, and eventually resolves because it runs out of resources, or the adaptive immune response expands and eliminates it. And that adaptive immune response, that's the T cells, that's the B cells, that's the antibodies, takes a long time. You figure it out mathematically. You've got one T cell that's specific for the flu, it's got to find its target, and then it's got to grow. So that takes weeks in order to happen. So by vaccinating, we can mimic those weeks, because the secondary response, remember, you're protected after a vaccination against chickenpox, against the development of chickenpox, because you have a very rapid immunologic memory immune response against that microbe. That's what we're trying to achieve with cancers when we immunize against cancers. Now, we've used vaccines for many, many years. We've used them in the wrong setting. We've admitted it. We've used them in advanced patients to try to get these vaccines to eliminate cancers. But the fact is, we know that the cancers can eliminate the T cells because they've developed these roadblocks. And so our use of cancer vaccines in more recent times has been to prevent disease from occurring, either primarily, so to prevent it in the first place, or secondarily, after an individual has been treated to prevent it from coming back. There's a number of strategies. I'm not going to go into all of the different strategies that we use, but remember that I told you that there's proteins on the outside of tumor cells. There's proteins on the outside of normal cells too. We've developed ways that we can understand the proteins that are displayed in these MHC molecules, these HLA molecules that are out on the outside of tumor cells, so that we can formulate vaccines that are specific for the tumor. This is just one great example of we're targeting a protein that's encoded by your own genome, but is aberrantly expressed by the tumor. And as you can see, we can identify those regions that are expressed in the tumor microenvironment, and we can immunize you against those regions so that you have a more robust response once that tumor starts to, if it does, start to come back. And that's something that we've been working on now for the last several years, is to try to prevent relapse in individuals who are at high risk for relapse. And this vaccination strategy, in much the same way that occurs with tetanus, in much the same way that occurs with smallpox vaccine, leads to durable immune responses so that you can be protected for many, many months or years as a result of vaccination. I'm not going to go into all of this, but this just shows that we can vaccinate, we can get increased levels of T cells, and those can stay around for months in individuals. And plus, we have the option of continuing to give boosters. So for example, tetanus, we continue to boost every 5 or 10 years or something like that, because the immunity against tetanus toxin wanes to the extent that we need to provide boosters to retrain the immune system to have a high enough level of anti-tetanus antibodies in the bloodstream. And in fact, one of these clinical trials is one of these vaccines is moving forward into an advanced clinical trial, really to answer that question. And this was actually activated yesterday at the Mayo Clinic. We have a large phase 2 clinical trial in patients with high relapse risk triple-negative breast cancer. So these individuals have been identified by their staging and have been deemed at high risk for relapse. And what we're hoping to do after their conventional therapy, which is for triple-negative breast cancer, cytotoxic chemotherapy, and surgery, treat them with a vaccine that targets specifically that tumor. And so this particular phase 2 clinical trial is going to involve 2 arms. It's going to be randomized, it's going to be blinded, and it's going to ask the question, is this vaccine effective at preventing relapse in those individuals. And if it is, these patients can go on to many more years without having a relapse of their disease, because a relapse in breast cancer is what's associated with death. So monoclonal antibodies is something that we've focused on also extensively in the past several years, a couple of decades. In fact, Mayo has been instrumental in advancing our understanding of how to use a monoclonal antibody called trastuzumab. And trastuzumab targets a specific molecule called HER2/neu on the surface of tumor cells, and it's most notably associated with breast cancer. So there's a subset of breast cancer, for those of you that know about breast cancer, that's called HER2/neu positive disease. And in fact, we've been instrumental both in understanding how trastuzumab works in the adjuvant setting, so patients that have been treated for the disease with surgery and chemotherapy, but also for the use in treatment of metastatic disease as well. And in fact, this is actually samples from Winston, one of his clinical trials, in which we looked at patients that have been treated with chemotherapy and trastuzumab. And this looks at overall survival. So those patients that didn't develop immune responses to their cancer had poorer outcomes than those individuals did. So that's telling us that what happens is once we infuse trastuzumab into an individual, it generates an endogenous immune response, much like a vaccine. So one of the things we're asking is, in those individuals that didn't respond to trastuzumab and chemotherapy, can we boost their immunity? And we've created a number of different vaccines that specifically augment the type of immune response that we're seeing following the delivery of trastuzumab to individuals with breast cancer. And we'll be conducting a phase 1 clinical trial to determine whether or not that's safe. Another thing that we're employing at a number of different levels is cellular therapies. And this is just an example of adoptive T-cell therapy with so-called CAR T-cells. So these are chimeric antigen receptor T-cells. So we're taking the T-cells out of the body, and we're actually making or reconfiguring them so that they recognize your tumor. We can do this with innate cells too. So we can stimulate the type of immune response that is needed to eradicate the tumor. So I'm not going to go into all of the technical details here, but what this involved is synthetic reconstruction of a number of different molecules that we can actually put in through the use of a variety of different viral techniques into T cells, a number of different unique, innovative constructs that recognize the tumor specifically. We can grow up those tumor cells or those T cells in dishes, in culture dishes, and we can infuse those back into individuals. And this has been very effective in some cancers and can completely eradicate, in many cases, the cancers and lead to lifelong or extended, persistent, durable immunity, protecting these individuals from relapse. This is just an example of a study that was taken from a patient that was being treated with glioblastoma. You can see here a number of different images where they had tumor, and this individual was infused with a T cell that had been reconfigured to recognize specifically a molecule in the glioblastoma, and after several infusions, you can see out here at like day 289 or day 295, the complete absence of that cancer. So the T cells that we can take out of the body, reconfigure to recognize tumor, and then infuse those back into an individual can be effective in eliminating the tumor and providing durable responses. But probably the most important therapy that's been developed, and Mayo has been instrumental not only in identifying the molecular interactions that occur immunologically, but also the clinical testing. You heard Dr. Ferrugia talk about Dr. Joseph's involvement with a patient early on in this symposia that had a complete clinical response following treatment against this particular molecule, PD-1. And remember, PD-1 and PD-L1 or B7H1, which is the other name that was initially given to. These are part of that checklist of molecules that decide whether or not to turn on or turn off an immune response. And so we can block those interactions. And there's a couple of ways of doing that. But here's shown biologically what happens. You have a tumor cell or an antigen presenting cell, and it upregulates these molecules called PD-L1 or B7-1. And the molecules that what we call immune checkpoint inhibitors are actually monoclonal antibodies, and those bind to these molecules, either PD-L1 or PD-1, and they inhibit those interactions. If you inhibit those interactions, your T cells become more cytotoxic, they become more active, and as a result have better or demonstrate better killing. And certainly, here's a great example of a patient who had malignant melanoma, had a recurrence following grafting, and this is a patient who was initially treated following failure of another checkpoint molecule, ipilimumab, and this individual was treated with an anti-PD-1 antibody following the recurrence of disease, and you can see after 3 cycles treatment, so just a few short weeks, this individual had complete clearance of the tumor. Many patients have durable immune responses that can continue to protect them from the disease recurring. There are some cancers that benefit more. So this is melanoma, for example, from immune checkpoint blockade. And this is what we call a waterfall plot. Without going into all of the technical details, this looks at the decline or the change in tumor size. So down means shrinking and up means growing. And as you can see, with checkpoint blockade in melanoma, there's a lot of cases in which there's a lot of shrinkage. Melanoma is one of those cancers in which is amenable to immune checkpoint blockade. In contrast, there are some cancers that are not. This is ovarian cancer, one of the cancers that we work on in the laboratory, and we have very few responses. And so we're trying to think of better ways that we can activate the immune system. And that could be with the use of PD-1 antibodies that block the PD-1, PD-L1 inhibitory axis. Because we know that there's a number of molecules that are called checkpoint molecules. Some of them activate T cells, some of them inhibit T cells. And we know those molecular interactions, and so there's a number of clinical trials in which we're testing combinations of an anti-PD-1 blocker plus an activator of T cells. One of the things that we're doing is actually developing vaccines. So some tumors don't respond because there's no pre-existing immune response. And so we know that. Some patients have better immune responses because they have responses to anti-PD-1 therapy because they have an existing immune response in their tumor. But what about those patients that don't? So we've been developing unique vaccine strategies that we can combine with immune checkpoint blockade. And this is just an example. We use animal models in which the animals develop breast cancer or ovarian cancer, and we can develop vaccines which can almost shrink the tumor for a while, but eventually it grows back out. And if we combine that with checkpoint inhibitors, these are tumors that don't have any active immune response against them, we can get 75% complete regression rates in these animals that develop breast cancer in this particular case. So there may be opportunities to go beyond the usual thinking of vaccines as prevention strategies and employing those vaccines with immune checkpoint blockade to further enhance the activity. So with that said, I'll conclude that what I think, and that what a lot of immunologists think, is that we need to be doing more during the disease-free period to boost host immune defenses. We know host immunity, what that means is your immune response can protect you from disease relapse. And so we need to continue to identify strategies such as vaccination that can help activate that immune response and prevent that tumor from coming back. So we know that vaccines can be developed against a wide variety of different targets, not only microbial targets in the case of, for example, cervical cancer, but also in non-viral, non-bacterial cancers such as breast cancer, ovarian cancer. There's a number of different strategies that are being developed that activate the immune response in addition to vaccines that I talked about, adoptive T-cell therapy, adoptive cellular therapies. How can we take the body's immune system out of the body, modify it, and give it back? And then antibody therapy. This has been one of the most intriguing areas and one of the first areas in which we had a lot of success, rituximab and Herceptin. How can we make that better? That only works in select patients. How can we make that better? How can we make it work in more patients? And lastly, where all of the excitement is, of course, is with the immune checkpoint blockade. It's very highly successful. So it really provides the rationale for continuing to understand immunobiology and how to improve the types of therapies that we have that target the tumor by activating the immune system. And with that said, I thank you for your attention, and I can take some questions.